My name is Gabriele Gasparini and I am an interventional cardiologist, and about 16 years ago I started to use radial artery for coronary angiography, standard PCI, and even more complex intervention. 4 years ago I approached for the first time the concept of distal radial access, that is itself an evolution of the forearm radial technique. To date, I have performed more than 300 procedures through the distal radial artery. The distal course of radial artery is more superficial and runs along the bone, which makes it easier to compress, suggesting its potential role for faster and easier hemostasis. Additionally, puncturing distally to the superficial palmar branch theoretically preserve antegrade flow through the radial artery, even occlusion of course, preventing thrombosis over a long segment. Basically, the main advantages of this approach are reduction in terms of risk of RAO, preservation of the antegrade blood flow through superficial palmar arch, reduction in terms of risk of compartment syndrome because the arterial entry is behind the compartment of the forearm, preservation of radial artery for future catheterization, and last but not least, it could be used as a main site for retrograde recanalization of RAO. Additionally, in case of left distal radial approach, we have the traditional advantages of left approach over the right and specific advantage of left distal radial approach over standard left radial approach, such as patient comfort and operator comfort and safety as well. Obviously, as for any other arterial access, we have also some limitation. I mean, we have an higher rate of failure even for experts operator. Additionally, the course of the vessel is more tortuous, that can create some potential dissection. And in case of tall patient, the standard length of guiding catheter could not be enough to engage coronary ostia. And finally, we can carry some risk to scaphoid blood supply or digital ischemia, as we reported last year. When we consider the distal radial approach, we have to keep in mind that the radial artery is on average 0.5 millimeters smaller than the forearm radial artery. So larger sheath size plays a role in radial spasm, and it is associated with pain during sheath insertion and removal. According to this consideration, ultra-low profile sheaths are the preferred device in distal radial access. The thin wallet technology provides a 1 French reduction in outer diameter compared to a traditional introducer, maintaining the inner diameter equivalent to conventional one. The current available ultra-low profile sheaths are the glide sheath slender from Terumo and the range sheath from Cordis. And one of the limitations of ultra-low profile sheaths is represented by the risk of kinking. However, there are no published studies comparing current commercially available ultra-low profile sheath introducer. So, in my personal experience with distal radial approach, this problem may be overcome using an ultra-low profile sheath with a kink recovery technology that reduces the risk of kink. Once kink occurs, It rebounds to complete recovery to initial profile, a key factor in reducing the radial artery spasm and the risk of radial artery occlusion. Distal radial artery represent a promising alternative to conventional transradial approach. So I'm strongly convinced that mastering distal radial approach is an investment in the best outcome for patient and in higher quality of one's interventional practice. Thank you very much.